Hello, everyone. Thank you for joining me. I am Gabriel Allaf. I am a psychiatry resident. Today's presentation focuses on the intersection of psychiatry and cardiology, specifically how psychiatric disorders like depression, anxiety, and somatization influence cardiovascular outcomes, treatment adherence, and also patient well being. During the presentation, we will explore relevant studies, pharmacological considerations, and practical approaches to patient care. As a slight introduction, cardiovascular disease is the most common chronic illness in the United States, with nearly half of adults affected. What's often underrecognized is the bi-directional relationship between cardiovascular disease and psychiatric disorders. Patients with mental illness are more likely to develop heart disease, and those with heart disease are more likely to suffer from depression, anxiety, and adjustment disorders. This connection isn't just a stat. It has direct clinical implications on morbidity, mortality, and quality of life. Depression is actually the most common psychiatric comorbidity in patients with cardiovascular disease. It actually impacts 17 to 27% of cardiac patients, yet often goes unrecognized and also untreated. Depression has been shown to independently predict outcomes like rehospitalization, recurrent cardiac events, and even deaths. In fact, depression's impact on mortality rivals that of traditional cardiac markers like ejection fraction. Depression after acute coronary events or cardiac surgery is particularly impactful and should be systematically screened for. So, what are the overall mechanisms linking depression and cardiovascular disease? Well, the overall relationship between depression and heart disease is multifactorial. Behaviorally, depressed patients may be less likely to follow dietary, medication, and also exercise recommendations. Physiologically, depression activates the HPA axis, resulting in increased catecholamines, endothelial dysfunction, and cystatic inflammation. Platelet aggregation is also increased. These changes contribute to arrhythmia, ischemia, and atherosclerosis progression. Decreased heart rate variability, a known risk factor for sudden cardiac death, is also very commonly seen in patients with depression. MI survivors with depression face significantly increased mortality. One study found that patients with depression had a 3.5-fold increase in 5-year cardiac mortality. The risk was comparable to that of patients with reduced left ventricular ejection fraction or a history of previous MI. This underscores that psychological factors can have prognostic significance equivalent to biological markers. Depression may also impair rehabilitation participation and also medication adherence, which further creates a compounding risk. In heart failure patients, depression actually predicts incident congestive heart failure and those with underlying coronary artery disease. Among patients with CHF and AFib, depression is associated with worse long-term survival. Additionally, patients undergoing valve replacement who remain depressed have twice the mortality rate compared to non-depressed counterparts. These findings reinforce the importance of mental health assessment across all types of cardiac pathology, not just post-MI patients. Now, anxiety in cardiovascular disease. Anxiety disorders are common in chronic cardiac conditions, with prevalence estimates around 5 to 10%. Although the evidence linking anxiety to heart outcomes like mortality is less robust compared to depression, anxiety can still significantly impact quality of life and reduce adherence to behavioral recommendations, especially in smoking cessation. Anxiety also increases perception of somatic symptoms, which may drive excessive utilization of emergency services and unnecessary diagnostic testing. Many patients with non-cardiac chest pain suffer from panic disorder or somatization. Predictors include being female, being under the age of 50, lacking objective coronary artery disease findings, and overall high baseline anxiety. These patients often undergo repeated cardiac evaluations, including angiography, despite no evidence of ischemia. Differentiating between somatic symptom presentations and true angina requires both clinical judgment and collaboration with psychiatry or psychology. Effective management can reduce symptom burden and overall healthcare costs. Now, cardiac devices and psychiatric outcomes. Psychiatric complications are also very common amongst patients with implanted cardiac devices. ICD recipients often experience anxiety, avoidance behaviors, and PTSD-like symptoms, especially if they've received shocks in the past. LAVAD patients face challenges including lifestyle restriction, caregiver burden, and also device-related anxiety. Studies show that depression and anxiety have a greater impact on quality of life than ejection fraction in these patients. Pre-implant counseling and CBT have shown to reduce psychiatric complications in these patients. Now let's discuss treatment. Several large trials have examined whether treating depression improves cardiac outcomes. The first study mentioned on the slide, SAD Heart, found that sertraline was safe post-MI, but did not significantly improve cardiac endpoints. The next study showed that CBT reduced depression and social isolation, but did not reduce cardiovascular events. The third study mentioned on this slide, CREATE, found that citalopram was effective in treating depression. However, interpersonal therapy added no additional benefit. Overall, while we can treat depression safely, there is no definitive evidence yet that doing so improves cardiovascular survival. That said, symptom reduction and improved quality of life are compelling enough to justify treatment. However, there are some considerations regarding psychopharmacological medications. SSRI antidepressants are generally first line due to their favorable cardiac profile. Sertraline and citalopram are the best studied and have minimal cardiac side effects. As a note, TCAs should be avoided. They can prolong the QT interval, increase heart rate variability, and lower the threshold for arrhythmias. Mirtazapine appears safe post-MI, but may cause weight gain. It is also important to be aware of drug interactions, especially SSRIs with clopidogrel or NSAIDs, as these may increase bleeding risk. So the overall recommendation is start low, go slow, and monitor closely. So in summary, depression and anxiety are highly prevalent in patients with cardiovascular disease and significantly influence their outcomes. Even though treatment may not alter mortality, it does improve function, adherence, and overall quality of life, making psychiatric care a critical component of comprehensive cardiac care. Screening tools like the PHQ-9 or GAD-7 should be routine. An interdisciplinary model incorporating primary care, cardiology, and psychiatry will offer the best outcomes. Do not wait for mental illness to stabilize on its own. Engage your patients early, treat them proactively, and advocate for integrated care. Thank you so much for listening to my presentation today. And here are some references for your own interest and references that I used also for this presentation. Again, thank you for listening and thank you for your time.